Hello everyone. In this lecture, we are going to discuss some of the pathologies of spleen. So first we'll start with splenomegaly. First we'll discuss what are the causes of splenomegaly. Now the causes can be divided into, various subheadings. It can be due to various infections. It can be due to congestion. It can be lymphohematogenous conditions. It can be due to immunoinflammatory conditions. It can be because of some storage disorders, or it can be because of some miscellaneous conditions. Now let's start with infections. Infections are very important causes of splenomegaly. Now, virtually any bloodstream infection can cause splenomegaly, but I'll just write down the important ones. So, among the bacterial infections, tuberculosis, syphilis, and brucellosis, these are the important causes. Then among the viral infections, Epstein-Barr virus, which causes infectious mononucleosis, and cytomegalovirus, they can cause splenomegaly. Among the fungus, histoplasma is one of the important cause. Histoplasmosis is one of the important cause for significant splenomegaly. And among the parasites, there are various examples, like among the parasites, important ones are the malaria, Kala-Azar caused by Leishmania donovani, otherwise known as the Leishmaniasis. Then trypanosoma infection, histosomiasis, and echinococcosis. Echinococcus classically it causes the hydatidic cyst. Okay, so these are the various infectious causes. The important infectious causes which cause significant splenomegaly. Okay. Then the second one is splenomegaly due to congestion. This I will discuss in other slide separately. Then the lymphohematogenous causes, basically the lymphoid malignancies, lymphoid and myeloid malignancies, they can cause splenomegaly. This we'll discuss separately when we'll discuss about the blood malignancies. Then we have myeloproliferative neoplasms. Under myeloproliferative neoplasms, chronic myeloid leukemia and primary myelofibrosis, these are known to cause massive splenomegaly. Okay, massive significant splenomegaly. But any myeloproliferative neoplasm can also cause splenomegaly. Then we have plasma cell disorders, and also hemolytic anemias, especially the extravascular hemolytic anemic conditions. Okay, so hemolytic anemia, these are associated with splenomegaly. Okay, so these are the important lymphohematogenous causes. Then among the immunoinflammatory causes, because spleen has both the lymphocytes which take part in the immunological reactions, and it also have the blood cells. So splenomegaly can happen in any immunological condition, and it also happens in various hematological conditions. Under this heading, important examples are rheumatoid arthritis and systemic lupus erythematosus. Rheumatoid arthritis and SLE, they are associated with splenomegaly. Then the storage disorders, we'll discuss more on this under the section of genetics. So basically, Gaucher's disease, Niemann-Pick disease, mucopolysaccharidosis. In all these conditions, there will be splenomegaly. This is because in all these conditions, there will be deposition of abnormal materials, especially the abnormal lipid materials inside the macrophages. Okay, so spleen is storehouse for macrophages because this is also a reticuloendothelial system organ. Okay, so because of increased lipid deposition inside the macrophages, there will be splenomegaly in all these conditions. Okay, again we'll discuss all these things under genetics section. Miscellaneous conditions include amyloidosis, then neoplasms, It can be primary neoplasms or it can be secondary neoplasms and cysts, splenic cysts. Okay, so this is the this is the broad heading or subheadings and the important causes for splenomegaly. Okay, of course there are so many other conditions. I have not mentioned all the conditions, but these are some of the important conditions. Okay, among these we can remember like what are the causes of massive splenomegaly? So causes of massive splenomegaly include malaria. This include malaria, Kala-Azar or leishmaniasis, then CML, primary myelofibrosis. Okay, and some of the lymphoid malignancies, they can cause massive splenomegaly. And among the lymphoid malignancies, one of the important ones I want you to remember, that is hairy cell leukemia. Okay, hairy cell leukemia. We'll discuss again this separately, but one of the important lymphoid malignancy is hairy cell leukemia, which is associated with massive splenomegaly. Okay, again, it is not very important at this point of time to remember all these things, because when you study the individual topics, you'll be able to remember them that time. Okay, so these are the causes of splenomegaly. Now we'll discuss some of the individual entities. The first one is non-specific acute splenitis. Okay, so non-specific acute splenitis, it is very much similar to what we have discussed for non-specific acute lymphadenitis. Basically, it can happen in any bloodstream infection, especially bacteremia, bacterial infections. Okay, so what happens in this condition? There will be increased inflammatory response. So basically, the inflammatory cells, especially the neutrophils, they'll come. They'll come from the systemic circulation and they'll get deposited in the red pulp of the spleen. Okay, so this inflammatory cells, they will be released from the from the penicillary acidules into the red pulp. So there will be congestion of the red pulp. Okay, so classically there will be congestion of the red pulp because of infiltration with inflammatory cells. Okay, so increased inflammatory cells, especially the neutrophils and also sometimes eosinophils. Also, there will be predominance of the plasma cells. Okay, predominance of the plasma cells because of the infections, the B lymphocytes will be activated, and once they're activated, they will produce the plasma cells. So in the red pulp, you will find infiltration of acute inflammatory cells and also the plasma cells. So that will cause congestion of the red pulp. Okay, and sometimes this congestion can be so severe that this inflammatory infiltrate, it can go and it can encroach upon the white pulp areas. Okay, so sometimes this red pulp congestion, it can encroach the white pulp area. Of course, there will be some proliferation of the white pulp area because it has the T lymphocytes and B lymphocytes, but there is predominance of red pulp congestion. Okay, there will be increased size of the spleen. So here in these conditions, the size of the spleen will be around the weight of the spleen. The weight of the spleen will increase to around 200 to 400 grams. Normally, I told it is around 150 grams. The maximum point is 200 grams. Beyond that, it is due to splenomegaly. So in these conditions, usually the weight will increase mildly, that is around 200 to 400 grams. What is going to happen in the follicles? Similar to what we have discussed in acute non-specific lymphadenitis, sometimes these follicles may undergo necrosis, especially if it is due to hemolytic streptococcus. And this necrosis, it can liquefy and it can form pus. Also. Okay, so these are the findings we are going to get in non-specific acute splenitis. Coming to the next condition, that is congestive splenomegaly. Congestive splenomegaly means in this condition there will be congestion of the spleen. Okay, so there will be splenic congestion because of impaired venous drainage. Okay, so venous drainage of the spleen is impaired. Now, if you see here, this is the splenic vein, as we have discussed previously. This is the splenic vein. Splenic vein, after coming out of the spleen, in the inferior mesenteric vein will join the splenic vein. Then the splenic vein will combine with the superior mesenteric vein to form the portal vein. The portal vein will go into the liver. From the liver, hepatic veins will come out, hepatic vein, and the hepatic vein will join the inferior vena cava. So this is the inferior vena cava. It will join the inferior vena cava, and inferior vena cava will ultimately drain into the right side of the heart into the right atrium. Okay, so this is the complete venous drainage of the spleen. Now, the impairment of the venous drainage can happen at various places, and this is divided into three subgroups. One is the pre-hepatic causes, pre-hepatic conditions. It can be due to hepatic conditions, or it can be due to post-hepatic conditions. Post-hepatic conditions. We'll start with the pre-hepatic conditions. Basically, before the liver, there can be obstruction in the portal vein. There can be obstruction in the portal vein, or there can be obstruction in the splenic vein. So, portal vein can be obstructed, or splenic vein can be obstructed. So, these are the causes for pre-hepatic impairment of the venous drainage. So, portal vein obstruction, this can happen. Portal vein obstruction can happen either because of portal vein thrombosis. It can happen because of portal vein thrombosis, or it can happen because of inflammation. Okay, inflammation inside the portal vein. So that is known as pyelophlebitis. Infection or inflammation inside the portal vein, that is known as pyelophlebitis. So these are the causes which can cause portal vein occlusion. Splenic vein obstruction, splenic vein occlusion, usually it is caused by neoplastic extension of carcinoma, stomach, or pancreas. Okay, so splenic vein occlusion can happen because of neoplastic extension of carcinoma, stomach, and or pancreas. Then we'll discuss the hepatic causes. So basically, cirrhosis. Cirrhosis is the condition, liver cirrhosis, which will cause intrahepatic occlusion of the, intrahepatic occlusion of the sinusoids that will ultimately lead to increased pressure in the portal vein. So basically, all the causes of cirrhosis can cause increased pressure, increased drainage of the portal vein, leading to increased portal vein pressure. So that is known as portal hypertension. Okay, so all causes of cirrhosis can cause portal hypertension and ultimately congestive splenomegaly. Okay, important examples under this heading you can remember: alcoholic cirrhosis, pigment cirrhosis, classically described in hemochromatosis. Then, of course, there is a classical cirrhosis, or you can say classical type of liver fibrosis that is described in patients with schistosomiasis, that is known as pipe-stem fibrosis, schistosomiasis. It's a very important question for exams. So pipe-stem fibrosis is classically found in schistosomiasis that can also cause portal hypertension and congestive splenomegaly. Next, we'll discuss about the post-hepatic causes. So post-hepatic, there can be occlusion in the hepatic vein itself, which is known as Budd-Chiari syndrome, BCS, Budd-Chiari syndrome. Again, this we'll discuss in liver pathology. Or sometimes there can be some cardiac conditions. There can be some cardiac issues, which is ultimately impairing the venous drainage from the inferior vena cava. So cardiac conditions, especially the right heart failure. The most common cause of right heart failure is again left heart failure. So any heart failure can cause this congestive splenomegaly. Also, constrictive pericarditis. Any condition which leads to impaired inferior vena cava drainage into the right side of the heart, that will lead to this congestive splenomegaly. And also there are certain right-sided valvular causes like tricuspid stenosis or pulmonary stenosis. They will also increase. This is the tricuspid valve, and we'll also have the pulmonary valve, which is present between the right ventricle and the pulmonary artery. which are not shown here. So whenever there is stenosis of the either the tricuspid valve or the pulmonary valve, there will be increased right-sided heart pressure that will impair the drainage of venous. I mean, impaired venous, that will cause impaired venous venous drainage from the inferior vena cava. Okay, so these are the post-hepatic causes of congestive splenomegaly. Okay, so these are the etiologies for congestive splenomegaly. Now we'll see what is going to happen whenever there is congestion. So what is the consequence of congestion? So whenever there is congestion, there will be increased pressure inside the splenic vein. There will be increased pressure. Okay, so that will cause impaired venous drainage from the spleen. The splenic veins are nothing but these are continuations of the trabecular veins. Trabecular veins are continuations of the pulp veins, and pulp veins are continuations of the splenic sinusoids. So ultimately, it will cause sinusoidal expansion. So sinusoids will be expanded. The sinusoids will be expanded. And also there will be collagen deposition in the walls of the sinusoids. Okay, so that will cause the sinusoidal walls rigid. So they will have rigid walls. Okay, so these are expanded and they will have rigid walls. So basically sinusoids, they are present in the red pulp. So again, there will be congestion of the red pulp. Congestion of the red pulp. Okay, sinusoids are expanded and they will have rigid walls. Also, there will be splenomegaly. There will be splenomegaly, of course. So size, I mean, the weight will increase to around 0.5 to 1 kg. It can increase up to 0.5 to 1 kg. And the capsule will also become fibrosed. Capsule will also become fibrosed. The red pulp, initially it will be congested, and ultimately, if this congestion persists, that will also become fibrosed. Okay. Now, what is going to happen to the cords? So basically, the blood cells, they will enter from the cords to the sinusoids through the openings. So if there is increased pressure, inside the sinusoids, this process of transfer of blood cells from the cords to the sinusoids is not going to happen. Okay, so this process is again impaired. So these blood cells will get trapped inside the cords. Okay, and if they stay for a longer time inside the cords, these blood cells will be engulfed by these macrophages which are present in the cords of bilirubin. Okay, so increased sinusoidal pressure will hinder the incoming blood cells. Okay, it can be RBCs, it can be WBCs, it can be platelets. Whenever these blood cells, if they cannot go into the sinusoids, they have to stay in the cords. And if they stay in the cords for a longer time, they will get exposed to the macrophages that are present in the cords. And these macrophages will phagocytose and they will destroy these cells. Okay, so that is going to cause pancytopenia. I mean, this is what we see in hypersplenism. Okay, so that is hypersplenism, resulting in pancytopenia. Hypersplenism means increased activity of the spleen. Okay, so increased activity means increased activity of the macrophages. Increased activity is seen because these macrophages, I mean the blood cells, are exposed to the macrophages for a longer time. Okay, so these are the consequences of congestive splenomegaly. Okay, coming to the next condition, that is splenic infarcts. So splenic infarcts happen because of arterial occlusions. Okay, spleen is an organ. Spleen is an organ which is at increased risk of embolization. Okay, along with brain and kidney. Along with brain and kidney, spleen is at increased risk of embolizations. Okay, especially from the heart. Especially this embolization happens from the heart.